good morning, and I'll go ahead and call our meeting to order. This is welcome to the Indiana Commission to Combat Substance Use Disorder for our November meeting. The minutes were distributed prior to the meeting and are in your folders. Can I have a motion to approve?
Second.
Motion seconded. All in favor?
Aye.
Thank you. So we have a full slate of presenters this morning, but before we get to them, I just want to mention that in your folders is the November 2022 Next Level Recovery Progress Report. It is 9 pages, and it highlights the work of all the state agencies, and it recognizes that despite a record number of overdoses, we're doing what we can to help keep people alive and shepherd them into services once they're ready. So you'll find a copy in your folder, and then also at the end of today's meeting on our website, it will be posted as well. So I quickly want to take a minute to highlight the state's naloxone efforts. And through our partnership with Overdose Lifeline and the Division of Mental Health and Addiction, Indiana has invested over $9 million in naloxone in just 2.5 years. We've distributed over 173,000 doses since March of 2020. Overdose Lifeline is distributing about 14,000 kits every month, and they've had more than 1,180 reversals that have been reported back to them since last September. And please note that this figure is way underreported, as a vast majority of naloxone reversals are not reported back to any sort of system within our community. But it is encouraging to know that there is so much naloxone out there. I think our overdose rates would be incredibly higher if we didn't have that level of naloxone in our communities. So I just want to say thank you to Overdose Lifeline, DMHA, and then also our partners in the Department of Health, who are continuing to supply our first responders in our rural counties with naloxone as well. So I want to introduce our first speaker. That is Charmin Gabbard. She is the Executive Director of the Fayette County Connection Cafe. And I've had the opportunity to meet Charmin on our travels. I get to see all the work that she does in her community with the Spring Service Program. She just recently spoke to the Chief Justice's Mental Health Conference, and as everyone knows, and for anyone who may not have attended our meetings before, we always start our meetings with a recovery speaker to share their story. So, Charmin?
Thank you. So I appreciate the opportunity to come here to share today. I share my story because I know that our stories either hold us back or they give us that power to move forward. Growing up, I was born into a family where my parents had about a 7th grade education, and they got married when they were 15. My mom had my oldest brother 4 days after she turned 15 years old. And so my father was a factory worker and an untreated alcohol. He had an alcohol use disorder. And my mom had a gambling addiction. So my first childhood memory comes from just a time of where my dad was beating my mom. And I only recall lots of instances like that, or where in my home, love looked like it was angry and violent. And I say that I learned 3 things very early on: don't talk, don't tell, and don't feel. When they would fight, like, we would cry, and they would just tell us to hush. And so at 6 years old, I was taken to the woods and sexually abused by 3 of my cousins. And I kept that secret because I knew telling my dad, for me, the fear of telling him and knowing that I was going to be beat as a result of that. So that secret, like, I learned to keep those secrets because, one, we didn't talk about what was going on in the home, and we lived outside of town across the creek, so we were way out in the country, and there was just never no help. And by the time I was 9 years old, I had been molested by both men and women, and then my mom started taking my sister and I to the store to shop with. And this became a way to cover up for the gambling. I didn't understand it as a kid, but my dad worked hard. He was trying to better us. We had a 4-room shack, no running water. We would take baths in the creek in the summer, and that was just, we worked hard, we raised gardens, but my mom was just a very sick person and untreated mental health issues herself. So my first drink of alcohol was around 9 years old, and I think that was a feeling. I was always looking for something because there was no love, there was no security, and that gave me this like feeling of warmth and maybe just I compare it to sunshine on a day when you walk outside and it hits your face. And that was the entry for what was to come. By the time I was finished with 8th grade, I had missed 80-some days of school. I had already had a suicide attempt, and my mom had cancer. So moving forward into high school, I just didn't go. I didn't attend, but I would travel on that bus to town so I would get away from the house. And they never talked about goals or dreams in our home. And my only goal was to get out of their house. It was just so angry and violent. There's 3 other siblings. I wasn't I didn't conform to just settling. I always tried to help my mom. And so moving forward in what should have been my senior year, but I didn't have the credits. I would just go and skip or whatever. But I had found that cluster of friends of fitting in, and my senior year, I was admitted into an adult treatment center for alcohol use disorder. I had acute liver damage at that time at 17 years old. After that treatment, I ended up leaving home and moved away. Made it to Mississippi and had my first kid 2 weeks before I turned 19. My cycle, everything that I resented about my parents, I became. My dad always told me that I was worthless and I'd never amount to anything, and I don't know that I had any goal to ever amount to anything, other than I knew when I would have kids, I was going to be a different parent, and I wasn't. I continued my cycles of shoplifting and DUI, and I entered the prison system in 98. My DOC number is 981606. So I was always an incorrigible child, all these labels, worthless, and then I became a number. And I cycled in and out of prison until 2014. I have 13 felonies, somewhere around 30 arrests. I was a low-level, nonviolent offender. I was the same person that would go in, that would come out. There was just never nothing more. And I wanted different, and I would promise my kids. I ended up having another son, and I couldn't change. I would promise them the world, but every time more lies, more trouble, and finally, in 2013, I left the system, and within 6 months, I was back in, and it was for habitual traffic violator, another Class C felony, going back in for another 4-2, and I said, I can't do it anymore. I'm just tired. And I remember my mom was my first drug dealer, too. Backing up, at 13 years old, I worked Pioneer. And as long as I would give my mom money for bingo, she would buy me half gallons and drop me off in town, half gallons of whiskey. So there was always this like trade-off, and that's just who we were. So then I ended up doing drugs with my 19-year-old son when I came out of prison in 2013. Within that 6 months, going back in, I just didn't want to live anymore. I hated everything about the woman I saw in the mirror. I couldn't change. I had so much heaviness in my heart, and I was just so exhausted. There was nothing left in me. And I knew those kids deserved better. I went to jail in Union County, and I had a plan to take my life. Thankfully for me, some things changed along the way, and I did go back to prison again. But this time when I got to Madison, a director of a program called me to her office, and she said, Sharman, take this time for you to work through all those things that keep you and keep you coming back. I didn't know how. People would say if you loved your kids, you would just stop. Like, I didn't know how to forgive my parents. I didn't know how to forgive myself. all the shame, and along with the drinking and drugs came multiple more incidents of sexual abuse and just things that I couldn't tell because no one believed me anyway. And my word never held weight in our community. I was a liar, drug addict, and thief. And that's exactly how I was viewed. And that's how I have been treated. I've had law enforcement that have, I've been spit on. So I really thought that's what I deserved, was that life. Working through some things in that program and learning to be different. I started running while I was in prison, but I had that 19-year-old son and all of his friends that called me mom. And I just started anything that I could get a hold of, any positive meditations, just whatever it was, and started going to church, and just a woman from the outside came in and worked with me for 32 weeks, gave me 2 hours of her time, a woman in recovery. And I started praying for God to show me the truth in my life, where I needed to forgive and where I needed to ask for forgiveness. It was no more, I'm sorry. It was about my actions needed to match my words. And I had a right now changing moment in January of 2014 in prison, and I knew that my spiritual journey, and I knew my addiction was taken from me, without a doubt. I left prison in April of 2015, and I had a GED that I had gotten as a patient in a state hospital because there was always a place to put me. I was just a problem, but the state hospital. And I was determined. I had no driver's license. I got a job doing landscaping and mowing like 5 days after I came home. And I started school, online classes. I would run 5 miles to town. I stayed with my parents for a few months, and I would run just to go volunteer at a recovery setting or get to a meeting. I wanted to be different, and there was only AA in our town and Celebrate Recovery. And just little by little, I just kept showing up, and then I showed up at the Drug Coalition, and they were like, let's introduce ourselves. And at that time, I still spoke with a lot of stigma. But I was like, I'm a drug addict and alcoholic, and I just want to make a difference. And the sheriff that had arrested me multiple times was on that board. And a year later, he ended up nominating me to the board, and I'm now the vice president of that board. But when I started learning that I could and that I was worth something, I ended up getting an associate's degree in human services. And someone had thrown me a little get-together, and my parents showed up for like 10 minutes, and none of my family came. I was the first person in either side of my family to get a degree and go to prison too. And then I went back to school, and then I got my bachelor's. I started recovery coaching classes, and the sheriff would let me in the jail. I started sharing my story, and just the more I advocated, the more I shared my story, the more people I met along the way. And I am a person of faith. My steps and all these doors have opened for me. I started working in the health department in harm reduction in the SSP. And I was making like $9 an hour, 3 part-time jobs, going to school full-time. But whatever it was, I was willing. I was like, they let me work at the courthouse with all these felonies. And ended up now, we have that program. We started a nonprofit, and it's called Connection Cafe. We integrated a recovery community organization in with the harm reduction program. We serve about 125 people a week. I am the co-founder of the Connection Cafe. We have 3 employees that make really good money. They have benefits, a retirement plan. We have 3 interns, and we serve, I think I said that, about 125 people a week, 6 different types of groups, but it's a judgment-free, stigma-free space, just so people can come and be loved, no matter what that looks like. In February, I'll have 9 years of recovery. And I guess and then my youngest son is 16 years old, and he's my cycle breaker. Like, it's possible to break the cycle with love and support, and just being heard. Sometimes I don't know, I just had so much shame. I just wanted somebody to love me just as I was, without all that junk. And today, I love the person that I am, and I can look in the mirror and, I'm proud of her today. Yeah, that's, thank you for letting me share.
Well, Charmin, thank you so much for being here. And if anybody's out on the road, you're in Connersville, stop by the Connection Cafe. Charmin will show you around. They're doing great things. They're helping not just connect people to treatment and recovery, but they've got a lot of other services there as well. So thank you. Thank you for being here. So our next presenter is a familiar name to many of us. Dr. Brad Ray is a senior justice and behavioral health researcher at RTI International. He's previously held roles at Wayne State University and Indiana University. Dr. Ray and our teams at DMHA and the Management Performance Hub compared overdose deaths over a 90-month period with several statewide administrative data sets, like incarceration, prescription dispensation, emergency medical events, to identify the most common touch points and where resources should be situated to reduce overdose. So we've invited Dr. Ray to present on his team's findings.
Thanks, Doug. Hopefully everybody can hear me okay. I want to thank Charmin for that testimony as well. Everybody, my name is Brad Ray. I'm a senior researcher at RTI International. Today I'm going to be discussing about a 5-year research trajectory around record linkage that I've been engaged with, as Doug mentioned, with several Indiana state government agencies. I'm going to talk about some of the earlier findings we've conducted from studies that we published, but also some preliminary findings from research using statewide data in Indiana, and then discuss how we're working to make these data actionable at the local level across the state of Indiana. So much of my research in this space has been inspired by some folks out of Massachusetts, Mark LaRochelle and his team there, and they have been using record linkage to identify what they refer to as touch points. Now, when I say record linkage here, what I'm referring to is linking multiple sources of data together at the individual level. So we might take all the persons who have died of an overdose and link them to all of the persons that have been released from prison and see how many of them link up. And in doing this across multiple data sets, we can identify touch points, which are those opportunities where we see individuals manifesting in those data sets frequently as opportunities where we might be able to mitigate accidental overdose deaths. So my interest in this initially started examining jail data in Indianapolis. As I'm sure many of you there are aware, the research suggests nationally, research suggests that people leaving carceral settings like jails and prisons without treatment or harm reduction resources are at an incredibly high risk for overdose and death. So to examine this in Indianapolis, I led a study where we used what's called a cohort design. So we actually looked at every single person who left the jail in the calendar year 2017, and it was about 27,000 individuals. And then we record linked these to 3 years of all of the accidental overdose deaths in that county. And so what we find here is that in doing so, we found that of all of the overdose deaths that occurred in Marion County in the year 2017, 21% of those overdose deaths were people who had been released from jail sometime during that year 2017. When we looked at all of the overdose deaths in 2018, you can see there 20% of all of the overdose deaths in 2018 were people who left the Marion County Jail at some point in 2017. When we look at 2019, 22% of all of the overdose deaths in 2019 were people in that 2017 jail release cohort. So in this study, we estimate that at least, and it's a very conservative estimate, that at least 1 out of 5 overdose deaths are people who were recently released from jail. And we did find that those persons who were booked on syringe-related charges had 3 times the hazard of death. But a big limitation that we had in this study is that it was only one county. So if you were arrested, for example, in Hamilton County, we wouldn't have had that information. So what we wanted to do is to expand this study to look at overdose deaths across the state of Indiana over a longer period of time, but also look at additional touch points beyond jail. So what you see here is information on all overdose deaths in the state of Indiana for more than 7 years. So it's 2015 through August 26th of this year. So this was just over 60 days ago where the data end. And we wanted to do that in part to demonstrate how near real time we can do these analysis, which I'll talk about a little bit more in a bit here. But these are the demographic characteristics of more than 13,000 people. And I don't want to just skip over that number. That is a lot of people to have died of an overdose in a 7-year period. Those are entire communities. And that is just a lot of loss and trauma and grief and anger that is left behind. And as you can see here, more than twice the number of people died of an overdose in 2021 than compared to 2015. So it just kind of speaks to the ongoing struggle we have for this public health problem and where we need to continue to innovate and see what's working. I also want to point out in the lower left-hand corner there, we did look at all overdose deaths, but it's important to know that the vast majority of overdose deaths are coded as accidental overdose deaths. When you hear about the overdose epidemic nationally, when you hear about it in Indiana, this is the category of overdose deaths that people are continually talking about. This is the category of death where we're seeing the massive increases. Are there increases in those other ones? Sometimes, some places, yes. Is there a gray area between those and accidental? I'm sure that there are. That is the nature of the medical legal death investigation profession, is to minimize those types of errors. But by and large, these are accidental overdose deaths, and accidents have the ability to be prevented. Let me go, there we go. So these are all of those overdose deaths record linked to 5 different data sources. The first data source are jail bookings. So these are people when they're booked into jail, not when they're released. The second data are prison releases. So these are when people are released from prison. The third data set are prescription drug monitoring records. This is from the PDMP in Indiana known as INSPECT. And in that we look at 2 different touch points. One is buprenorphine dispensation, and then one is just any opioid dispensation. Our fourth category there, fourth data set is the emergency department. And the last one there is EMS. So one thing I just want folks to know as I go through some of these results is that we're not looking, when we say that there is a touch point for jail or prison or EMS or ED, in those categories, we're not looking specifically at drug-related offenses or opioid or overdose-related emergency medical events. It's just any, at this point, any touch point in any of those systems, right? And the other thing I want to note is that all of this record linkage is done through the Indiana Management Performance Hub, which I'll talk about their role a little bit more here in a second. But my research teams can coordinate through them to ingest data for very specific use case scenarios into their enhanced research environment, which is a hardened environment where we cannot get data out. We can't even get analysis out without review, depending on that level of granularity. So it's a very secure environment to do this type of work with what can be very sensitive data. So to briefly walk you through this table and what we have done to identify some of these touch points, which you'll see first in this table is prevalence. So this is how frequently we detected that person in another data set within the 12 months prior to their death. We also include the frequency, so how frequently were they in that touch point and the time to the last touch point. Then over there to the right, you can see how I've calculated the the touch point rate. So what we see there is the average number of those events, so the average number of all the jail bookings per year in the state of Indiana, and then the rate. So to kind of talk you through one of these as an example, starting with the jail booking touch point, you can see there about 26%, which is a little bit higher, but still consistent with what we found in Marion County. Again, we only had one county there. This would be statewide. But you can see 26% of individuals who died of an overdose death were booked into a county jail in the 12 months prior to their death. The average number of times was 1.7 over that 12-month period, and the time from the booking until that person deceased on average was about 5 months. Now, if you look down at the next one, you can see the prison touch point as at around 3.4%, right? Now, if you look over to the right, though, which you can see, and as I'm sure many of you have surmised, far more Hoosiers are booked into jail than they are released from prison. So about an average of 690,000 bookings, jail bookings per year, compared to about 11,000 jail releases. When we take this information into consideration and we calculate a rate from these touch points occurring, what you can see there is about 7 out of every 100,000 jail booking events 71 of every jail booking event results in an overdose death, compared to about 569 out of every 100,000 prison releases. So looking at all of these data sources, what you'd see there is that the prison release has the highest rate, followed by EMS and jail for the rate of those events occurring. But for the prevalence, it is the emergency department that has the highest prevalence of the touch point, followed by the prescription opioid dispensations and EMS. And I actually think all of these numbers, all of these ways that we're looking at are important to provide this information to communities to make decisions about where they can place actionable interventions to reduce overdose deaths. And just to kind of go over one more of these, taking a look at that prescription event, it runs sort of in the opposite direction of prison. So you can see that 59% of people who died of an accidental overdose death had an opioid prescription in that 12 months prior. However, when you think about 13 million prescriptions, only about 8 out of every 100,000 dispensations resulted in an overdose touch point. So we explored these touch points over time. And what you can see here are the changes in those rates over time. Given how high the rate was for release from prison, I had to create a separate y-axis there. But generally, we see some increases across the board, but the greatest ones in prison, jail, and the EMS touch points. And this is again the rates. Looking at the prevalence of those, we see some decreases in the ED and prescription touch points, but increases in the EMS touch point in particular. There's quite a big increase in the prevalence of that touch point there. I'm really putting this as an example, but we explored all of these touch points and their variability by the demographic characteristics of the decedent. So, we can see whether or not persons who were male, who were persons who were white, if they had higher or lower prevalence of these touch points. So for example, in this slide, we look at differences in dichotomous measured gender. Males, you can see, were significantly more likely to experience both of those incarceration touch points, jail and prison. Females were more likely to experience the prescription touch point. So we've examined this across all the other demographic characteristics as well. So where we're going next with this is really exciting for me to tell you all about. We recently received funding from the NIH to do a 5-year study, and this is with myself and some colleagues from the Indiana University School of Medicine. This study is called Fortress, so you'll hear us talk about that a lot. We're pretty proud of that acronym, and it stands for Fatal Overdose Review Teams, Research to Enhance Surveillance Systems. So as part of Fortress, what we're going to be doing is working with local county overdose fatality review teams across Indiana. For those of you who are unfamiliar with these teams, they're a fairly large multidisciplinary collaboration that brings together, in many cases, more than a dozen local stakeholders coming together once a month, sometimes more frequently, sometimes slightly less frequently, meeting to conduct in-depth case reviews. and they do a case review on usually 2 or 3 overdose events in their community per month every time they meet. These are very coordinated case reviews with they're very facilitated. Information is collected from them. This whole process of using case reviews to look, and the reason they're looking through these case reviews, collecting information from them, is to look for patterns, to look for opportunities where they could implement local changes to reduce overdose deaths. This process of reviewing cases to identify these patterns, it developed largely out of child fatality review teams that were around in the 1980s. But one of the things that sets overdose review teams apart from child fatality review teams are simply the sheer number of the events that they're looking at any given time. There are far more overdose events. And many, OFRs have to set eligibility criteria. So as a way to sort of narrow down the cases that they're looking at. So they might say, we're just going to be looking at deaths that involve females, or that just involved opioids, or that just involve veterans, as a sort of a way to narrow that down. So our plan with Fortress is to take this information, this preliminary information that I presented to you on touch points, and develop that into a near real-time dashboard that these OFR teams can use to supplement, or I'm sorry, to support, not supplement, support their case review process. And our hope is that these OFR teams will have the ability to drill down to the local level to look at these touch points to see how they compare to the state, and be able to monitor those touch points over time. So for example, if you said, ED is a very high touch point in our area, we want to put forward, practices, standardized practices for what happens in our emergency department, getting people linked to treatment and services. That local OFR could monitor that touch point to see if there were changes in it. And as part of that, we'll also be doing some training and technical assistance with these teams on what some of those evidence-based practices are that they can implement across these various touch points. Now, one of the reasons that we selected Indiana for this study is because the Indiana Department of Health manages a very robust network of county level overdose fatality review teams, which in Indiana are called suicide and overdose fatality review teams. We actually did a survey a couple of years ago of overdose fatality review teams across the country and found that no other state had as robust of a network that was tied in and supported by state government as Indiana. So that was a huge opportunity. And so what we'll be doing, sort of our early work, will be to develop these dashboards. And what we want to do is make sure that the dashboards are customized for overdose fatality review teams. So we'll be creating this expert panel of folks who have been involved in overdose fatality review teams nationally, on how they're designed, on how they're implemented. And then we'll also be bringing persons from the community into that, both individuals with lived experience, but also members from a pilot county that we'll select in Indiana to be a part of that expert team. So our goal here is really to make sure these dashboards are for the suicide and overdose fatality review teams, and that it can be used as part of their case review process. So there's sort of a seamless integration in there. Besides a large number of well-functioning SOFRs, Indiana also has the Management Performance Hub, which has overcome barriers to data integration that many states have not, and it's really, hoping to illustrate that by this touch points analysis. But also MPH has experience in developing real-time dashboards with their naloxone heat map, and there just are not places that are doing things this innovative, and especially in state government. I can tell you now, I have an opportunity to work with state governments across the U.S., and less than a handful of states could do anything like this, and none of them have a robust network of these OFR teams that are engaging local stakeholders on a regular basis. So to me, that's one of the most exciting parts of this project, is to take some of the knowledge, some of the evidence that we know about, and take that directly to individuals at the local level. So that is all I have for my presentation, but I'm very happy to answer questions now or answer them afterwards, whatever works for the committee. I'll stop sharing here.
Are there questions for Brad? And so Dan just, he can't see us, so if you'll just, oh, well, can't see that half the room, so.
What is your level of confidence? And just a footnote to that question, I'm thinking about near misses. And the denominator may be larger if it includes near misses, and it might change some of the analytics, maybe not significantly. I don't know. I'm just curious, as your national experience, if you have a view as to
I don't want to interrupt, but if there are questions, I can't hear them, just so folks know.
I can't remember what my question was. It's on? I'll make it more succinct. My name is Dan Evans. I'm with IU Health. My question is accuracy of coding. So you used can you hear me?
Brad, can you hear him?
I can only hear you, Doug.
Okay, so Dan's question is to accuracy of coding. How confident are you in the accuracy of the data?
We're not able to assess the MPH record linkage process. What we did do, Dan, to get at some of the quality of the data is we looked just back in time. So when we actually looked at like 2012 data, the EMS stuff wasn't there, so we weren't seeing EMS record linkage occurring. So we looked for data normalization to occur. But yeah, we can't assess how the record linkage is done, and that's just a limitation of this work. But in terms of how things are coded, I feel very good about that. Because again, we're not looking with the particular analysis I just showed you, we're not drilling down to see, was it an opioid related event or an overdose related event? It's just this person was in the ED or this person was seen by EMS. And I do feel very confident in their record linkage ability.
Does the PDMP, was that going to help or not?
I hope
so. So the PDMP keeps track of overdoses also in the PDMP. Is that correct or incorrect? I thought as a provider, we're supposed to be able to see if someone's had an overdose and we're therefore more cautious because 58% of these people had a narcotic prescribed for them before their death.
That is something I have heard about, the ability to have a flag for non-fatal overdoses in, I believe in the ED setting, people could look on there when they're going to prescribe. I don't know where that's at. I'm not really too involved in that. I think Kara Slusser could probably speak to that better than I could. And I hear what you're saying about that 58%. I would keep in mind that some of that is medications for opioid use disorder. And the thing there, and we could really spend an hour talking about this, is these folks, there are very large increases in the dispensation of buprenorphine in Indiana, which is good, which is great. What we're seeing, though, is that people are just getting buprenorphine for a period of time and then not continuing that. So as I've talked to others in Indiana about the movement nationally is what we call low threshold buprenorphine. That is not taking people off of buprenorphine because of minor non-compliances with their treatment. What happens then, so just hypothetical example, you have somebody coming in, taking buprenorphine, they take another substance with that buprenorphine, the provider might then say, you're cut off, you're not allowed to do that. The problem is when you do that, when you cut somebody off of buprenorphine, they'll go out, they could find illicitly produced opiates, which almost all have fentanyl in them. They have no idea their tolerance for that particular substance, and when they use it, they overdose and die. So it is about getting people low barriers to continuing that buprenorphine treatment when they're on it. Sorry to ramble there.
Thank you.
Dr. Box, to answer your question, Deb Fry, Indiana Professional Licensing Agency, and we administer the INSPECT program for Indiana. That's a project that we're working on to collect and have that overdose data readily available to practitioners. Currently, we do not, but it will be part of the alerts that are placed on a patient's record. And when the physician pulls up the inspect report, or practitioner pulls up the inspect report, that alert will be part of the information that's provided.
Awesome, thanks, Deb.
And one of the challenges were
Brad, this is Dr. Gutwein. Can I make one comment? I don't know if I'm allowed to. I think that it's interesting, the EMS touch points with these people was continuing to increase, but the emergency department touch points were decreasing. And I think that has a lot to do with how Narcan was distributed, how police are using it, how EMS are getting to the scene, and then not having to take that patient to the hospital. Because a lot of these people are getting Narcan from an overdose and then going back to work. And they don't necessarily ever come to the emergency department.
Yeah, that was exactly what I was just going to say, that as we have been distributing.
Sorry, I was muted there. I'm not sure. I have not looked at the EMS to ED linkage. What I will say is we recently conducted a study where we found that 10% of people, at least 10% of people who call 911 for an overdose call for service are booked into county jails within 6 hours of that event. So I think the problem there, when you don't see people going to the emergency department, is oftentimes because they're booked into jail. So when we did look to see the number one charge that individuals were booked into jail for, it was syringes was number one. Number two was paraphernalia. So that is, I think, a concerning trend. And what also concerns me about that is that we may be losing trust in our first responders. If individuals are calling for help and then being incarcerated, I find that a concerning trend.
Mm-hmm. Yeah, definitely.
And additionally, our SOR funds for the next year have low barrier threshold buprenorphine clinics in there as a funding point. So, any further questions? All right. Well, thank you, Brad. I appreciate you joining us.
Thank you for all that you're doing. I'm happy to be here and happy to continue to come back and update y'all on our progress with Fortress. Thanks, everybody. Good seeing you.
Thank you. So, as Brad mentioned, with 65% of individuals who have died from an overdose visiting an emergency room within, on average, 96 days prior to overdosing, this emphasizes the critical need for medication for opioid use disorder and addiction supports in our emergency room. So next we have Connie Kerrigan and Dr. Tom Gutwein from Parkview Hospital in Fort Wayne, who have a model for how hospitals can implement this. And they're going to share their experiences in bringing MOUD to the emergency department, the successes and the challenges. So Dr. Gutwein, thanks for joining us.
Yeah, thank you, Doug. Thanks for having me. I'm excited to share with you guys a little bit about our story here at Fort Wayne. So we're Parkview Health, Parkview Hospital. I'm medical director of the emergency department at Parkview Regional Medical Center. And just to show you a little bit, what we started this program a couple years ago, just after COVID started. And this is the first. This is an important slide. This is why we really took this approach. I want to share, these are some people that Connie knows. The gal on the left was a cheerleader in school, had 2 children, had been recovering from opioid use, was happy, and 2 days later, after this picture was taken, she died. She left her 2 children to the family, and it's a real tragedy there. And that was a friend of Connie's daughter. And then the gal in the middle was another gal that had 3 children in town, was happy, doing well, and also died of an overdose. And this happened within the past 5 years. And they didn't have a lot of access to Suboxone and things like that at that time. So I think it's important to know why we're doing this. Just like as Sharma shared her story earlier, we see different people that have this problem, and we definitely need to do what we can to break the cycle. So hopefully that's presenting okay. So with So what we did with this project, as I put at the beginning, there was several people involved in this project. It was not just myself, but it was also Connie, who was involved through the mental health aspect, and it was our pharmacist who was involved in the delivery of Suboxone to patients, along with Narcan and prescribing other medications to help people get through withdrawal. So we looked at the situation. Basically, there were a lot of inconsistencies on how people were getting help for opioid use disorder. I consistently saw patients in the emergency department that came in that wanted help for opioids. We would have them evaluated, and we said, this is an outpatient program. We can't do anything for you today. Just go home and try to show up at this clinic in a couple of days. And then good luck getting in. Maybe that'll help you. So, and we also looked at studies that showed that the medication-assisted treatment was effective, and that most people were, a majority of people were actually still in the program 6 months down the road and still on the recovery pathway. So what we wanted to do, we thought that our physicians, providers would all benefit, and these patients predominantly would benefit from a standardized process. And so we wanted to do a pilot program just in one of our emergency departments and then expand it to the others. And we made that decision so that we could start small, so that we also had at Parkview Regional, we have a pharmacist in the emergency department. At this time, they were in the emergency department from 3 p.m. until 11 p.m. So we thought we could catch on a lot of those patients and have them available to help do education for the patient on how to use Suboxone. We actually gave them a pill splitter so they could take an 8 milligram tablet and split it into 4, depending on what dose they need. So we had that available to us. So we started there, and we wanted to also make sure that they had an appointment, which I thought was really key, was to get them an appointment before they leave the emergency department on who they could follow up with, where, and what time, and have that appointment within 3 days. So to get this started, we had to have physicians and PAs that had X waiver or data, the X waiver to prescribe Suboxone. So we could give a person a Suboxone tablet, but then they would have to come back to the ED the next day. And we really do not encourage people to come back to the emergency department. Little do most people believe, but we don't encourage people to go to the emergency department all the time. If you guys work me out of a job and I can move to Florida, I'll be happy, but I'm still got plenty of patients to see. So we want patients to get the right treatment at the right time at the right location. And so we wanted our prescribers to get waivers. So at this time, when this started, you had to do a physician had to do an 8-hour course online. Usually, there were some. Actually, they were all basically online at that time because COVID had just started. And then if you were a PA or an APP, you had to do 24 hours of educational content. So to get physicians and PAs to do this, I had to throw a little bit of a carrot out there. So we were able to, so Connie, we worked through a grant and was able to get some funding for this education for our providers. So we put a $500, we gave people $500 if they did the waiver, and they were able to get that waiver completed. And we were able to get about 35 to 40% of our providers. It was right around 40% of our providers, and we have 100 providers, 60 docs, 40 PAs. We have 100 providers. So we were able to get about 40% of them their waiver. This was a year ago. And then I'll just say, since that time, you probably know now you don't have to take the educational class if you prescribe it to less than 30 patients. So now you can just apply for it and get it. And so we're up to about 60% now. We do not give anybody a financial incentive to do this, but we just encourage them to do this. And I think that one thing that really was a good telltale sign of things to come is that at a meeting we had in March with our physicians, just with our physician leadership, we had about 30 physicians there. And one of the physicians said, you know what, for the first time, I used my waiver and I prescribed Suboxone to a patient. He goes, this was the greatest thing that I could have done for that patient and to get them into treatment. And he goes, I think we need to mandate this for everybody. And so it wasn't just me carrying the torch to get people to get their waivers, but now I had some of my colleagues carrying that torch as well. So that was really, I think, a good movement to move forward. So basically, we get them the appointment and we give them the 3-day supply. And I'll go through some of these things quickly because I don't want to bore you too much. But I think as it's always important that we have an eligibility list. This was only for people 18 and older that were in active withdrawal. We do not do pregnant people. They need a little bit different care. And so we're working with our OB docs on developing a pathway for them. If they have a lot of psych issues that it's not really just a opioid problem, then they need some other help. We absolutely have to check inspect on all these patients. If they're a maintenance on methadone, they're not really candidates either, or if they have significant liver problems. So we still have to look at where those people can go, but that's not in our mainstream. And so we used the COW score. We did some education on that. And we the pharmacist in working with this wanted us to really have a cutoff around 13 for our COW score. I kind of like to go down to about 9 or 10 because I think those people are already starting to withdraw. So I like to get them started right away. But if somebody has a COW score of 5 and they don't need Suboxone immediately in the emergency department, then we can still send them home with that and teach them how to start tapering that on their own. And that's worked well. So the order set we put together to make this simple, the things are, we got to make it as simple as possible when you got 100 different people that are trying to do the same thing. So we put an order set together that has psychiatry involved, pharmacy, peer support. Our peer support coaches are incredibly important in this. And that's really the absolute, as far as one thing that everybody gets is a referral to have a peer support coach. And so somebody will contact them from a peer support standpoint. And then, so this is just a slide to show you in Epic. So we use Epic. So we have this is our set. So all I do is type in MAT for medication assisted treatment, or I can type in opioid, and this order set will come up. When the order set comes up, this is how it looks, and you probably can't see because the screen's probably a long ways away. But basically, it says there's easily to check off to get a psych consult, to get a peer recovery coach, or to have a different type of consult. And then also to, as we go on down, let me just move to the next slide. It's a little more clear. This is the bottom of the order set. So really, this is a one-page order set that gets the patients the referrals that they need. It gets the patient the labs that they need in the emergency department, like a urine drug screen or a pregnancy test if you need that, or a liver profile. And then it also gets them the prescriptions. So this was kind of interesting when I worked with Epic. They were able to now tie all this together. So I don't even have to go to the discharge part and try to remember what medications I want to give them. So this discharge stuff will give them the other medications that they'll need, like clonidine or Phenergan or Zofran for nausea, some medicines to help with those other withdrawal symptoms. This is just a little bit of a blown up score or blown up shot of the order set. And you can see right there, it has the nurse do it's everything from the inpatient consult to peer support, which is what we need. It's a pharmacy consult if they're in-house to do that. And then it's a nursing note to have them do the COW score. And then this is the bottom of that, which just gets the labs that I talked about. But it also then at the bottom initiates the medications in the emergency department, starting them at 4 milligrams of Suboxone and then redosing them as needed. And these are just the rest of the medicines. This is what we do then. This is how it works in the emergency department. This is a slide we just used for education. This is a patient handout that we give to every patient, and it says treatment day 1, day 2, and then when you flip it over, you have day 3 and day 4. But this is what the picture on day 2 looks like. It spells out in pictures what to do. Take a half a tablet at 4 milligrams or the whole 8 milligrams based on how much Suboxone they took the day before. And then they write it down at the bottom. So they can, let me go back to that. If you look at the bottom right here, they can write down how much they got so they know how much to take the next day. Up to 16 milligrams a day. So day 3 and day 4, we just show them the same thing. This is the back page of that same handout we give them that tells them that this is what they do for day 3 and day 4, and then they should be within treatment within that time period. That just says what they're doing, day 1, 2, 3, 4. This just reinforces our different disciplines that we have involved with this. Pharmacy, peer support, nursing, psych, everybody's involved with this. We have a checklist that they can go through, making sure that we use that medication-assisted treatment order set. That really gets the ball rolling and makes it easy for the providers, because the biggest thing is I have a doc that says, I want to prescribe this. What do I do? I tell them, you just type in MAT, M-A-T, and the order sets come up there, and that's all you have to do. And everything else pretty much takes care of itself. You have to talk to the patient a little bit when you identify that patient. And the patients that I've started on Suboxone, it's not every day you're going to do this. And I tell people this, it's going to be maybe once a month, or maybe it's going to be in 3 months. You don't know when that first opportunity is going to come. But when that person comes in and you can see, and the last guy I started on Suboxone told me that he goes, I've been doing heroin and I've been doing it for like 2 to 3 years. He goes, I have 3 kids. I have a job. I can't lose my job. I don't want to lose my kids and my wife and family. He goes, I need some help. And he had been about 18 hours since he last used. And so he was starting to get into some withdrawals. So I gave him his Suboxone there in the emergency department. I gave him a dose. I watched him for an hour and a half to 2 hours. He needed another dose. I gave him another dose, and I gave him the prescription, or actually at that time we were able to give him a pack of the medication, but now we do predominantly the prescriptions. And then he took that and went. So this was the big thing, to get waivered, and getting people waivered is a big important aspect of this, and you don't have to do a lot. I just put down a few things, keys to success. Get some support from pharmacy and mental health services. They have to be on board. Making sure that you also use a carrot instead of a stick to get your providers to do this. As I mentioned earlier, we paid people $500 early on in this to make it happen. Most people don't know how to prescribe it. It's an interesting thing, because some of them will complain, why do I have to do a course to prescribe Suboxone when I don't have to do a course and I can give people all this fentanyl we want, or these fentanyl patches, or all this kind of stuff, which is probably a good point, but nonetheless, this is where we're at today. And then the other part I put in there, you might have to provide support 18 hours a day, 7 days a week. And I put 18 hours because that was what I would do. I didn't get any calls after midnight or before 6 in the morning for it, but I would get a few calls from providers at a community hospital that says, I don't have my X waiver, but I have a person here that really needs this. And I have I have the ability to get online at home, and I could actually prescribe it. I review the record. I talk to the provider. I say, yes, this is an appropriate person. Let's get them started on Suboxone. I just put the prescription out for that patient to help them get that started. And then most of the time that provider would go ahead and sign up and get their X waiver and get that done. So they do need support almost 24 hours a day to help them just to get through these situations, because until they do it once themselves, they're always going to be a little hesitant and not be confident in what they're doing there. Where are we now? We're about 2 years into the process. We have about 60% of our docs and PAs that are waivered. Most physicians and PAs that haven't used it are kind of looking to use it. And then there's still a few, we still have some naysayers, some people that say, I don't want to give these people another opioid, is Suboxone, that type of thing. So there's a few people like that. And then the other part is that timely follow-up is really important here. I put inconsistent, but that's that's a gap that we have today. So we're not 100% on 2 to 3 day follow-up. We're very close, and I continue to work on that as a project. So I think, yeah, that's about the other part that I didn't mention here. I don't think I have a slide. I don't. The other part that I think is really good that we're working on now is the Narcan distribution. And we're very close to having a Narcan vending machine at our Parkview Randalia emergency department. We have a little outdoor area that's covered that used to be a smoking booth that, since you can't smoke anymore, it's kind of isolated, or it's kind of open. So we're going to try to get a Narcan vending machine in there. And I think that, if we can do that at all the communities, that would be great. The other part that I would tell you is that we started this at Parkview Regional. It quickly, actually everybody in the community said, I want to do this too. I want to do it at Parkview Noble, Parkview Wabash, Parkview Huntington. So we rolled it out to the rest of the hospitals almost within 30 days, just educating the nurses on what was going to happen, and then also making sure that the computers were set up to do all the prescribing appropriately. So we do this across our system. We have about 250,000 emergency department visits a year. And so we have at least this opportunity for every time that somebody comes in that wants help, they can get started on the proper help. Rather than feeling like I can't really do anything to help you today, good luck. So I think that most of the people are on board, not 100%, but I think that clear majority are. It works well. Again, we have a group of physicians that practice across all the Parkview facilities, and then also at Cameron Hospital in Angola. That's kind of our background. So, any questions?
Questions for Dr. Gutwein?
I went kind of fast, but I hope I didn't take too much time.
Dr. Box?
Dr. Gutwein, this is Chris Box, State Health Commissioner. I just want to say this is an amazing program and something I would love to see rolled out in other emergency rooms across the state. I was hoping that you and Dr. Weaver could work on the Indiana State ER physicians to maybe implement similar programs. I was wondering, though, if you have a lot of shortage of mental health providers for support for this follow-up.
That's a good question. There's always a shortage. Well, there's a little bit of there is a shortage. We all know there's a huge mental health shortage. But I think that this follow-up is a little bit of a niche. And I think that there's been an expansion of the availability of this. And I think I talk about like Wabash, and I know Bluffton, and on the southern part of Allen County, and then in Allen County. So that's a little bit of a challenge. And actually, I'm meeting this afternoon with our addiction physician here at Parkview to try to streamline that a little bit, because his last comment was to me, I can help you guys get these a little bit more consistent. So it's important to get that. I think that there is a shortage, but just kind of, working with those mental health people, they want to get these people in also, and they do get them in, they get them an assessment, and then they'll get them started on the medicine. So I feel good that we're able to meet this. I think there's a lot of the mental health gaps that I see are really like children with depression or children with behavioral issues that can't get in to see somebody for a long time, or people with, or even adults with those types of things too. If they're not connected to this system, it's really hard to get started in the system. So I don't know if I answered your question, but yeah, there's a shortage, but I feel like we have some people that want to help, and so we're able to kind of get some inroads in that.
Dr. Gutwein, this is Connie. I was wondering, did you want to talk a little bit about how you've seen paraprofessionals be part of the treatment process and what that's meant for your staff? I'm specifically referring to peer recovery coaches.
Oh, yeah. So I've been personally super happy with our peer recovery coaches and how they've been involved with this. But if you don't have somebody that has a peer recovery coach, it's just really they're kind of left out there on their own. So I see this as an opportunity. People come in to the emergency department. They're at that's our window of opportunity, because they're at a time when they want some help. So we got to get them that help right now. If we put that help off for 2 weeks or 3 weeks, they're back to work and they're back to doing what they had been doing. They're kind of not in that same wave of thinking. So you get that peer recovery coach in with them, because they're not going to have just problems with getting the Suboxone, but the peer recovery coach can help them do that. And we also encourage people to use that Good RX, because I think that actually does help the cost of their Suboxone. I think it's about $20. But having that peer recovery coach to just walk them through these challenges. And a lot of times, as you know, those peer recovery coaches have been through things like this. So they're super helpful in helping them understand and navigate through the difficult areas. But yeah, that's a, kind of a mandatory thing to have that peer recovery coach.
And this is Chris.
And Connie had some numbers on success. I think that it's about 68%. I think that we're, maybe more, that were still in treatment at 6 or 9 months. So, but most of them, maybe it was 68% that hadn't relapsed. I'm not 100% confident on that number, but it was really good numbers. So I think that we're making some progress.
Great. And Dr. Box has another question.
The next question, Dr. Gutwein, is, are you seeing any response from your obstetricians or your maternal fetal medicine specialists to engage with you? Because they could certainly be a consultant to get that OB patient that you're seeing in the emergency room started, and then back to see them within the next 24, maybe to 36 hours.
Great question. We have been working probably for the past 6 weeks on getting a specific order set for those pregnant patients. 20 weeks or less, more than 20 weeks, and how much they're using or what they're using. So yes, we're working directly with OB on that. And that's where I also want to get our addictionologist, his input on some of the best treatment for that too. Because I'm not the expert on Suboxone. My job is to make it happen. So I need to get this information from them. But yes, we are absolutely tapping into OB, and they are very willing to help us and work with us on this.
Thank you.
Any further questions? Dr. Gutwein, thank you for joining us today. Really appreciate your presentation.
Oh, thanks. Thanks, Doug. Thank you, everybody. Thank you all for letting me present. I'm excited about it. And if I can help in any way, please reach out. Thank you.
We will be. Well, so another place where we can have a tremendous impact in overdoses and the impact on substance use disorder is our jails. And so in 2019, as part of the governor's agenda, we announced our plan to expand access to treatment for incarcerated individuals with substance use disorders. And since that time, more than 4,400 individuals have been treated across 32 of our county jails. This year, we took another important step, and we're providing support for Hoosiers exiting the jail and transitioning back into society through the Integrated Reentry and Correctional Support Program, or IRACS. This connects incarcerated individuals across the 5 pilot counties, which are Blackford, Davies, Dearborn, Delaware, and Scott counties, with mental health and substance use disorders to certify as peers for reentry support. And this starts on day 1 of incarceration. And so for the first 4 months of operation of the IRACS program, 1,400 incarcerated individuals have been served. So we've invited Dearborn County Sheriff Shane McHenry and Aaron Spalding from One Voice to share what this program looks like in Dearborn County. And I think most critical to the program's success is local buy-in, and it's with support from Sheriff McHenry, local leaders, and especially that partnership with One Voice, who is leading the peer team that incarcerated individuals in Dearborn County are being connected. So I'll turn it over to you two.
Good morning. I'm going to have Aaron join me up front here. I'm going to talk, and then I'll introduce Aaron, and then he's going to have some remarks also. I had some things prepared, and it's kind of funny how things change. I wasn't sure how this was going to go today, who my audience was, but listening to these things really hit home. I mean, starting off with Charmin, unfortunately, I would like to say that's an isolated experience, but sadly it's not. Those are things we hear every day, and I think this is why you'll hear from what I have to say today, why the IRACS is so important to me and to be in our jail, because I think for far too long, folks like that have fallen through the cracks and not got the treatment or the help they need, and then just become another number that's in and out of the jail constantly. So I do want to thank the governor's office, and Doug's been a good partner. Unfortunately, my friend Jamie Whitaker's not here today. Jamie has been awesome to deal with from the start, and I wish he was here. I hope he gets better soon. When I was first approached about the idea of having the IRACS program in the jail, I frankly didn't know a lot about it, but quickly listening to these folks, how passionate they were about the program and what we could do, quickly I became a partner. I knew this was the right thing to do to allow these folks to come into the jail. I think for far too long, and I've been guilty of this, I spent most of my career as a detective focusing on narcotics. So what was my job? Let's just go out and arrest as many people as we can for narcotics things and put them in jail, and we're done, right? Like that's what we're doing. Well, as I got a little older and a little wiser, and then especially to cover as sheriff, I'm finishing my first term now, quickly realized, guess what? I've arrested grandpa, I've arrested dad, and I've arrested his son. And then when you look at this thing as a whole, it's like, what do we expect? They grow up in poverty, they're using marijuana, drinking with dad when they're 12 or 13, then they're committing other crimes because they don't work. And I mean, at what point do we look at this and say, this is the definition of insanity. I mean, we're doing the same thing over and over and over. You know, they're getting arrested for the same things, the same family. I mean, everybody in every community has those names. I could probably name the same three. Oh, you know, it's the Smith family. Here they are again. You know, we got, how many you got at Smith's? You go, well, I got about 14 of them in jail right now. And, you know, but unless we do something, how do we ever expect that this is going to change? So, like I said, it's just arresting the same people and making it a revolving door was not going to change things. So when I found out about this program, I was like, wow, you know, I could really see how this could be extremely helpful. Now, don't get me wrong, I'm not completely soft on crime here, and I realize that there are some folks who do belong in the jail and do belong to go to prison, but I don't know that a lot of the people that we have there are probably those folks. They may need to be in there for a short amount of time. I realize jails are not a rehab facility, but some need that for protection from themselves. I've seen far too many people get arrested, come out, they have no help, no programs, and guess what they do? They've been in jail for a little bit of time, they overdose, and then the next thing you know, we're investigating a death because they're using more than what they were, or using the amount when they went into jail, and now for being clean for a while. So the RX program gives the inmates in our community the opportunity to help themselves while being incarcerated without time cuts. Now, I think that's an important thing to note because we live in a pretty conservative community, and then when you start talking about inmates and access to all these programs, people kind of jump up and down and say, well, why aren't you helping so-and-so? These folks broke the law, so now they get special treatment. But the thing that I like for me is that, you know, these folks want to have to do this. You know, they're not getting time cuts. They're doing it for themselves to try to make themselves better people. So the RX program also addresses issues, and our previous presenter talked about the peer counselors, and I share his thoughts as those folks are rock stars. I mean, it's not like you and I trying to talk to these folks because, frankly, I've not been there, so I really can't say how they feel or the experiences they've had. You know, these folks have all, unfortunately, been in the jail, but they've done a great job to make themselves better people, and they're having a great effect on the folks, and I think they have, you know, instantly connections with the folks in the jail. But the one thing that really, really made me think about this program, what I really, really liked about it is, and I think the big gap that I always saw was we can do some folks or help some of these folks with some programs in the jail, but when they get out, if they've been there for a while, you know, most of these folks don't have a job. They have lost the place they live. You know, don't have a car, they don't have a license, they don't have IDs, they don't have anything. So what do? We let them out the jail or the Dearborn County Law Enforcement Center and say, good luck, you know, and then we expect that we're not going to see them back. Well, what do? Within a week, they went out, they go hang with the same people. You know, they're struggling because they don't have any money. They've either committed a crime, already went to probation and failed a drug test because they're back to using again, and guess what? Right back in within 2 weeks for a probation violation or something like that. So when I heard that what these peer counselors could do for these folks, I'm like, wow, like this really addresses the gap that I think is there. And when they were released, the goal is to have a photo ID, and hopefully that's a driver's license. Help getting them a job, a place to live, and then another thing that I heard, you know, we're talking about the shortage of mental health people. So we're releasing them. Obviously, most of them have some kind of mental health disorder or substance abuse disorder, or both. But if they're not getting connected to counseling or folks that can help them with that, you know, then they're out 2 months before, and then hopefully they're following up like they're supposed to. So one of the important things that I think the peer counselors are doing in the jail, and I've heard it firsthand, and I know Doug was there and heard this, is they're having appointments scheduled before they leave the jail. So the peer counselors are hooking these guys up with them, so they're not out and waiting 2 months. Just even maybe schedule an appointment that's now another month away. We're getting these appointments scheduled. We're getting the IDs. I think there's a partnership with the local license branch. We're working on, hopefully they're gonna be able to come over and meet with these folks, takes pictures to get their license, so they're ready to go. And obviously when we provide the folks with these kind of things, obviously that's gonna increase their chances of having success and not coming back into the jail. You know, the whole goal of this is for them to become successful citizens again. and we can give them the tools they need to do that. I was told the other day, and this is just one of those simple things I think we probably all take for granted. We had an inmate who works in the kitchen, and my mom runs the kitchen. I know, so you know who the boss of the jail is, right? So this inmate, she tells my mom, and he said, you know, these peer counselors are helping me get a license. And I thought, well, that's great, but you know, we have a license. But I mean, that was that important to that guy because he has never been licensed. But we expect this guy to go to work and have a job and do all these things when he's never even had a license. And it's something as simple as having a peer counselor available to help him with that. I think these are just kind of the small victories that I see occurring in our jail every day. And I know that we're doing the right thing. And I kind of, a little spiritual message here. I was listening to something on Sunday, and it really hit home with me. I really feel like these peer counselors are reviving some of these folks. And they're breathing life in these people who didn't have hope before, and that it's really catching on, and they're helping to prepare them for life after incarceration. Last thing I want to really focus on today is the positive impact the IRX program and peer counselors have had on the jail. Anytime you take on a program, you worry about everybody has staffing issues, money issues. How's it going to affect your jail? Well, we thought, there's going to be more people that we have to move around. Not sure. Maybe we need to look at hiring a person or two. Not sure how it's going to pan out. Well, guess what? It's been about staff neutral. The morale is higher than it's ever been in the jail because we have peer counselors available to talk to these folks. So we're not spending all day, pressing the buzzer and them asking the same question 22 times. And I'm not blaming any set of attorneys, but obviously when you get public defenders who are overwhelmed with the amount of caseload they don't have time to go to the jail every day and talk to these people. But now we have peer counselors who are available to talk to them. And, think about being in these folks' spot. Depending on what your charge is, you may be looking at prison time. Obviously, that's going to give you anxiety when you're sitting all there every day, having no clue what's going on, can't get a hold of your attorney. Not that they're necessarily neglecting them. They just don't have the time to do that. But when you have a peer counselor to say, hey, can you look up, when is my next court date? What about this? I know you've been there, and they put their minds at ease. So then they're not bothering my staff all day long answering these questions, and the staff is kind of like, man, actually, we feel like we can breathe and just do what we're actually supposed to be doing, which I think is huge overall. And there's no doubt in my mind, we're getting to the time of year where my population in the jail decreases anyway. But since we started this program for the past few months, I am positive, and it's a little early to say absolute numbers, but I see the jail population going down already, and I don't see the same names that I'm used to. Every day when I come in, I check the jail roster to see who's been arrested, just to get an idea where I'm at with things, and I'm not seeing those names. So I know even in a short amount of time, we're already seeing some success. And it's like the positive atmosphere I talked, not only with the inmates, with the jail officers, but now it's translating over to the inmates, because they're positively talking like, hey, have you talked to this peer counselor? I went to this group. What's your thoughts on this? So now everybody's excited about what's going on. So we've taken, the whole environment that's kind of a negative, like who's excited about being in jail? Maybe if it's a special meal on one day, and I don't hear too many great things about the food. Don't tell my mom I said that. So, but just the overall, with the inmates and the jail officers. So. Like I said before, I know we've only seen a small sample size in Dearborn County so far, but I think there's been so many positive things that have came out of this program already, and I have no doubt that this is going to be a huge success. I'm very proud of all the things we've accomplished inside the jail. Even more proud that we are recognized as a positive example around the state of Indiana because we're making a difference in the lives of those that need it most. But it is my hope that other counties around the state will have the opportunity to have this valuable and impactful program inside of their jail, because I have no doubt that it's going to work and we will be able to make a significant difference. With that being said, I'm going to introduce Aaron. Now there is a little bit, over here. So there is a little bit of backstory here, and I think this is kind of important from what you hear, kind of like what Charmin talked about with what she does with having a positive experience with law enforcement that maybe started out with a negative. Aaron and I have not always been on the same side of the law. I mentioned before I was a narcotics detective, and Aaron's name unfortunately came across my desk quite a few times. Aaron has spent some time in the jail, but guess what? Aaron has turned his life around and now is kicking butt, helping others. And I give this guy so much more credit than just what he's doing, helping to run my IRACS program. And I think another reason why Dearborn County is so successful is because we have really, really embraced recovery. Not only when they're in the jail, but when they get out. You know, there's places for these folks to go and hang out with other folks who are in recovery, so they're not stuck in bad places, you know, same things that they're seeing. And although I've got some pats on the back for allowing this program in my jail, these guys in the peer counselors are really the rock stars and are what are making this thing successful. I couldn't be more proud of this guy. He's a partner. He's become a good friend. And your next speaker is Mr. Aaron Spalding.
Okay, so good morning. This is an honor just to even be here right now and to stand in here. So my name is Aaron Spalding, and I'm the project coordinator for the Choices Coordinated Care Solutions and the supervisor of the Integrated Reentry and Correctional Support Program in Dearborn County. Our site, like shared before, is one of 5 pilot sites that was selected in a program through DMHA, Indiana Forensic Services, and Next Level Recovery. More important than that title, though, I'm a person in long-term recovery. What that means to me is I haven't touched a mood or mind-altering substance since November 29, 2015. I share this because it means that I, along with our team of highly trained peer professionals, we have this unique opportunity today to utilize our personal experience in overcoming our own battles with mental health and substance use disorders and the efforts of helping and supporting others. The Integrated Reentry and Correctional Support Program, IRACS, allows us to help others by providing answers that we once needed. It allows us to help others navigate the resources that we once needed as well, and allows our team to provide vital peer support services that each one of us could have used. Sheriff McHenry just shared, we do have a very unique history. The relationship that we now have today, it's not like it was in the past. Over 2 years of struggling with my own mental health and substance use concerns, I have plenty of experience from entering and re-entering that correctional facility. But the man that stands here today is the man that Sheriff incarcerated and regularly housed in the walls. And I share this because that means I too am the justice-involved population. I have justice-involved experience. I'm no different than the people that we help every day. I share this because I, along with other individuals just like me, are evidence of how someone's life can change if they're given proper access to community resources and evidence-based peer support services, in which I too utilized. See, my incarceration, I wasn't provided the opportunities that the IRACS participants get. I had many struggles. I had many setbacks after my release from Department of Corrections in 2012. Thankfully, though, Dearborn County has been very proactive in the implementation of peer support services, and I was able to get some services and some support that helped support my recovery journey. Unfortunately, many others have not been so lucky. As the data has shown, as we discussed before, those being released from a correctional facility are many times more likely to succumb to a fatal overdose. And this program allows this population, us to provide support to this population on those initial days from their release and walk with them through their reentry process and integration back into the community. As someone who has experienced as being justice involved, I can tell you that this is a moment that's filled with a range of emotions: fear, anxiety, frustration. Those are just a few of the negative emotions felt during this process. The support provided at that moment can be crucial to the successful reentry of these people. These support services are available to every individual within the Dearborn County Law Enforcement Center and each of these 5 pilot sites. There's a no closed door policy, meaning every individual inside these facilities receives some level of peer support services. This is a complete change in thinking of a typical reentry process and focus on each individual as their various pathways toward eventual reentry. In IRACs, this support and focus on the individual's reentry begins from the moment they reach the law enforcement center. Once incarcerated, our team of peer professionals begins the process of supporting their eventual reentry pathway and connecting them to the resources and services they identify to help them in the process. Each member of this team has identified roles and are able to focus on this participant when they reach their level of the program. So someone's first contact with the IRACs is meeting with our forensic peer. This role is to provide initial support, collect demographic and history information, and put it all together to understand what this person's story really is. Because we all have a story, and our story is important. By doing this, our team is preparing how to better support this specific individual. Once they have met with the forensic peer and completed the intake process, ongoing support services begin for the duration of their incarceration. During these, which are peer-to-peer interactions, we are able to provide support as they process the negative emotions that often accompany this process. Complete initial and recovery and reentry planning, and model to many for the first time just what recovery could look like. Each person's story is going to be different, as also each interaction. This is the first opportunity to let out a lot of what they've been holding in. As someone who's been involved with the justice population and the justice system, I know just how valuable this can be. As there's many times that I entered the correctional system and I had so much to say, yet no one to understand. This reminds me of one of our participants that I was meeting with when there was an intake process. It was an hour of the participant being angry, crying, but then also coming to an understanding of just where he is and how his life has been going. These were all emotions inside him that was waiting to come out, but they were able to come out with someone that was actually able there to support him. This is the benefit of having peer professionals embedded into the correctional facility. For many, the word recovery is foreign, and hope is a word that simply does not exist. Our team is able to relate to each individual's experience and provide them support based on their own. Simply, we have the ability to look them in the eyes, nod, tell them I get it, and me too. Since July 6th, the Dearborn IRACs team has begun this process with 253 participants for a total of over 1,900 peer-to-peer interactions. These interactions are an opportunity to connect with this individual, provide resources, and demonstrate that there is hope, that they have hope for their reentry. They have a chance to maybe not come back in there again. Once a participant of IRACs, there's also an opportunity to participate in our Matrix module, which is an evidence-based program that focuses on various topics from understanding substance use disorder, early recovery skills, and relapse prevention planning. This group is held bi-weekly, has been effective in providing the participants with these skills and promoting an atmosphere of recovery, just like the sheriff described. They have something to look forward to today. They have skills that they can utilize not just when they're released, but while they're in the cells, while they're in the pod, while they're with each other. By doing this, they're building natural supports with each other. They're challenging a lot of the old beliefs that they've had that's brought them in and out of the Justice Center. One of our Matrix groups, I've watched a participant that I've known and I've worked with over the years as a peer support in the community. And as I see him in this group today, he's changed the way that he talks. He's changed the way he responds to things. And it's not just me that sees this, the staff sees this as well. This is the beginning of what his recovery looks like. And for him, it's starting well before his incarceration. That's the opportunity we need to give every individual that is incarcerated. Once a participant has been identified with a release date, they get to meet with our resource navigator, which begins meeting with them to provide support and identify the needs and assist them in navigating the resources that's going to better support their reentry. And this is going to look different for every individual. Everybody's strengths are going to be different. Everybody's needs are going to be different. Everybody's legal proceedings are going to be different. But we're able to create a unique recovery plan just for them. For some participants, our team's able to coordinate with the court systems and divert from incarceration into long-term treatment programs. We've actually, since the introduction of this program in July, diverted 30 individuals from incarceration into treatment. For others, this means planning for the moment that they're going to walk out the door, their eventual release. But with this, we're able to be there the moment they're released. That's the beauty of this program, is by having these peers embedded within the law enforcement center, we're able to meet somebody at the door and walk with them through their process. For each individual entering reentry, our resource navigator walks them through what their personal situation upon release looks like. Goes over housing needs, employment needs, treatment, and connection to peer support services. Like the sheriff explained, appointments are scheduled, introductions are made, and the initial days of someone's reentry is mapped. The last aspect of IRAX is the peer professional reentry, is our reentry peer professional. And that's the individual that meets them at the door. They're helping coordinate that reentry process as it starts, and then following the first 30 days of the release. Doing a warm handoff with the community-based peer team through our partnerships with the Indiana Recovery Network and other local peer support agencies. They get to monitor their situation, meet with them on day 7, on day 14, on day 30, and be that extra support as they're developing their long-time support to move forward. These meetings could consist of providing transportation to an initial probation appointment. Because like again, the sheriff said, so many people without the support, without the resources, missed that first appointment, and here they are back. So we're able to walk them through that situation. Could be connecting them to the ongoing mental health and substance use treatment services that they've already have appointments to, but coordinate them and walk with them through it. And then coordinating them with their ongoing peer support services. I remember how overwhelming this all could be. It was really overwhelming when I had to do it alone. The focus of this program is to ensure that each individual being released has the immediate and ongoing support to where they never have to do this alone again. This program provides the opportunities that I, as a person that was once in justice involved, never had, but were the opportunities that I always dreamed of. Every time I approached a release, I always dreamed and hoped that everything was going to be different. Yet shortly I would get out and I would be back on the same path that I always was on. My plans didn't work, I didn't know who to turn for help, and I was alone. This is why this program must continue. And not just these 5 pilot sites, but hopefully across the state of Indiana. Every Hoosier deserves the opportunities this program offers, and no Hoosier should ever feel alone. Today, through the IRAX program, we have the chance to assist each person being released in creating a plan, connecting them to available resources, and providing them the support as we walk them through the reentry process. IRAX gives us the opportunity to demonstrate what recovery could look like, and that every person has the ability to change their lives. Thank you, guys.
Questions for the presenters? Yeah, Devin.
Thank you very much. Devin McDonald, I'm Executive Director at the Criminal Justice Institute. So thank you both very much for that. I really do appreciate it and really encouraged to hear about the success of the program. Quick question for the individuals that are in the program. Do you house them separately within the jail, or are they general population, or how does that work?
So they're all from general population. Now the ones that are actually in the groups that are working in a group together, they are housed all within themselves, so there's no security or risk of needs like that. But we work with people throughout the whole jail on individual levels.
Okay, great. Thank you very much. Appreciate it.
Yeah, that's one of the parts of the program.
is that it is easily implemented across various types of jails, different setups. It doesn't look exactly the same in all the 5 pilot sites. Chris?
My question is sort of along those lines, is this a distinct program, or does this have a relationship with other community corrections programs that Dearborn County administers?
So we also have a JCAP program, Jail Chemical and Addiction Program, which we've had for a while in one court, and then we also have a drug court program and a veterans court program. So they're really separate. I mean, I think there's ways they can build upon them. You know, some of these folks may start out in just the general IRACS program, but have the ability to maybe move on to the drug court program or other things. But honestly, and I meant that when I said it, I pride myself based on that because I do feel like we are a positive example around the state with all the programs we have, and there's no doubt I feel like we're making a difference with those programs.
Yeah, that's also the important part of our peers are part of the Recovery Hub network, and so connecting individuals when they exit back into those recovery hubs that we've been building are important to ensure the continuity of kind of all of our programming and not duplicating those efforts as well.
I too just want to say congratulations, first off, Aaron, for your continued recovery and then giving back to your peers. So good job on that. And Sheriff, I mean, wonderful to have such the vision, right, and definitely doing really good work. I know that my team from Indiana Department of Correction will definitely be in touch with you all. My question, though, real quick was, what is your average daily population, and then how many peers supports do you have? I'm trying to get like that ratio. Rough.
So it's kind of like a influx deal.
Just rough,
yeah.
I know.
So we'll go in the summertime, I'll sometimes be up. Usually we've been staying a little less than 280.
Okay.
I think when I checked yesterday, we're down into the 230s, which is fantastic. But I mean, that kind of goes down as it gets colder and things, but then for whatever reason, Easter weekend seems to be, let's start getting excited and outside again and getting in trouble. So then it starts to steadily rise from there, and we have, I'll let Aaron answer the second half of the total staff.
So for the peers, I'm the peer supervisor, and there's also 4 other individuals. One's dedicated strictly to groups, so we have 3 that provide individual one-on-one peer services.
Thank you.
And I do have a quick follow-up to the question before that. I should have said and I didn't. I think the important part about the IRACS program is when we talk about all these other programs we have, not everybody's eligible to get into those. So there's a lot of people that fall through the cracks, so to speak, or don't have the opportunity, and that's where IRACS becomes kind of the catch-all. So, and then really it's the majority of the population that aren't, because you can only put so many people in those programs. So that's been a huge help to get these other folks services.
Michael?
Hi, Mike Moore with the Public Defender Council. I got to go down and observe the program. Good to see you, Aaron. I saw an interview with the warm handoff, as you call it, post 30 days, with that person's peer counselor. It was a really impressive meeting. They talked about, they made a joke about, you spelled about housing. That was not their number one problem. It was driving. It was a couple other things too, but it was really interesting to watch that and be invited to that interview, that first meeting between the person who was released, posted in a 30-day recovery program, and then met with his peer specialist for the first time, the new one. So it was really good program. We're committed to helping Dearborn County, the PDs, get better contact with you all. Because I know that was a problem with maintaining contact with public defenders and your folks to do more informational exchanges earlier. So we're going to be working with you all on that. Good to see you again.
And a quick comment on that. I think we've done an outstanding job of collaborating with the defense attorneys, with the prosecutor's office, with the judges, so everybody is getting this information about what's going on with these folks, so everybody's on the same page. Obviously, with all those moving parts, you're going to have some hiccups, but I think it's went really well, and we're meeting once a month generally to go over some of these things, and I think there's been a lot of things that are getting helped, and frankly, the defense attorneys have been outstanding to work with, and I think it's been helpful both ways.
Well, thank you. I should have mentioned probably at the start, this program is funded through Recovery Works. There are the 5 pilot sites, but it's administered through the Indiana Recovery Network and their forensic group, which is headed up by Jamie Whitaker, who was having surgery today, so couldn't make it. But it's that group that's helping us implement this statewide. And we're having some meetings as we move toward the end of the year on what the next iteration looks like. We have other sheriffs who are just as supportive, and it's been really interesting. I've visited 4 of our sites. The collaboration that when the entire community comes together and the entire justice system is a partner in this, that's where we really start to see the almost immediate impact on not just the jail, but that recidivism. So really excited about the future of this program. I think we have a lot of sheriffs who are willing, and we have a lot of peer recovery coaches who are able to help. So we're looking forward to expanding this in the future. So thank you for being here.
Thank you all very much, and we appreciate you listening today because this is very important to us. Have a great day.
All right, our final agenda item, Director McDonald.
Yes, thank you very much. Just real quick update on a couple things related to the local coordinating councils. As you may know, CJI kind of helps oversee and provide guidance and ultimately provides information to this body about the approval of comprehensive community plans. Towards the end of this year, we'll have our initial annual report for last year's activities, so be happy to send that across once that's completed for your guys' review as well. One thing I would like to highlight with Michael and his folks that we have achieved about 90 of 92 counties have successfully completed and received approval for this year's comprehensive community plans. That's the largest number we've seen in several numbers of years.
Since I've been here.
Yeah. So the last 2 counties, I will say they're in different regions, 2 total different sections of the state, but the last 2 counties, so we will eventually have all 92. That's expected here in the near future. They are coming back up online, so really excited about that. Second quarter submissions, which run on the state fiscal year, so that's September or October, or July, August, September. We're due, of those, about 87 counties have already submitted all those reports, so again, pretty high number of compliance with that, so again, really excited with that. Our folks are continuing to work with the local coordinating council advisory group, which is a 16-member panel, folks from CJI as well as 13 individuals from local coordinating councils working to improve not only our interactions with the local coordinating councils, but interactions amongst themselves with networking and providing information across themselves. So continuing that partnership, and again, really excited to see where that's going. And then finally, our research division has been very active in updating a lot of the information from the CCPs and the reports that we receive. To updating dashboards on our website, which we'd be happy to share about spending, levels of funding at the local levels, activities, and things like that. So again, really excited that those bodies are really coming along and really enhancing the activities and the collaboration across the counties and upping their efforts. So pretty excited about that. That's all. Thank you.
Well, thank you. Any questions for Devin? All right. Well, I appreciate everyone's time and attention, and thank you to our presenters today. Our next meeting is Friday, February 3rd at 10 a.m. Here in the Indiana State Library. You'll also be receiving calendar invites for the 2023 meetings. Following today's meeting, we'll also be posting those on the website. So thank you. We stand adjourned.